Good morning, everyone. Thanks for being here. My name is Heloisa Soares. I'm a GI medical oncologist and the co-leader for the GI Clinical Trials Research Group at Huntsman. And I am here to answer your questions along with Dr. Jane. Dr. Jane?
Hi, everyone. Thanks for joining us this lovely Saturday morning. My name is Dr. Shikha Jain. I'm a GI medical oncologist at the University of Illinois, and I will be talking to you a little bit about colon cancer and answering your questions on colon cancer and updates. So, Dr. Soares, you want to get started with the first question you have?
Sure. So one of the questions that was asked was pre-op chemoradiation or in the chemoradiation group detrimental to surgical resection. Actually, based on the data that was presented, was not. Patients had a high completion of treatment. They also had excellent surgical clinical outcomes in terms of obtaining pathological response, which was higher to with the chemoradiation versus the perioperative chemotherapy. And they really did a good job in this trial to monitor the complications post surgery, and there was non-detrimental, including pulmonary complications. If you might recall from the presentation, ARDS was slightly higher in the group that received chemoradiation, but was not statistically significant. And other than that, the patients had a very similar rate of post-op complications, which was very encouraging because we, prior to this very well-controlled trial in terms of morbidity, we always had the sense that perhaps the patients will do worse in terms of surgical outcomes with chemoradiation, and it proves not to be true.
Great. So I will take one of the colorectal questions. So somebody asked the question. Well, first of all, I just want a statement I think that was made during my talk that was earlier. Somebody stated that they have a patient on Pembro on fourth line therapy since December of 2018. And this patient failed FOLFOXIRI, FOLFIRI, and then Lonsurf. And so they just wanted to give a shout out that they love immunotherapy, and they love the fact that they have a patient who's been on it for so long in this setting. Okay, so one of the questions that was asked was, what about the toxicity of immunotherapies and chemotherapy? So one of the trials that I discussed was the Keynote 177 trial. And so I think it's important to remember whenever you're looking at patients who are getting immunotherapy versus chemotherapy, we typically see a much improved adverse event profile, treatment-related adverse events in patients who receive immunotherapy. Usually the percentages are much lower. And we often, what I tell my patients when it comes to immunotherapy, most patients who receive immunotherapy do not develop those significant side effects, but the side effects that we obviously get concerned about with things like pembrolizumab and nivolumab are going to be the autoimmune side effects. So looking for pneumonitis, looking for diarrhea that can lead to colitis and perforation, looking out for things like diabetes and thyroid disorders. I often get asked, is somebody who has an autoimmune disorder, can they still receive immunotherapy? And the answer is absolutely. If somebody has, for example, type 1 diabetes or Hashimoto's or hypothyroidism, they can still receive immunotherapy. Just because they are getting immunotherapy does not mean that they are going to be at higher risk for developing an autoimmune side effect due to the fact they have an autoimmune disorder. So to answer the question of side effects, the studies basically consistently have all showed that patients who receive chemotherapy as opposed to immunotherapy, the chemotherapy arm typically has a higher level of side effects and more significant and severe side effects. And I also think it's important to note that when you do combinations of immunotherapy, you do sometimes see a slightly elevated level of side effects compared to one immunotherapy agent. However, in trials kind of across the board, we still continue to see that in those head-to-head trials, the immunotherapy agents still typically have a lower risk of developing severe side effects than patients who are on the chemotherapy arm.
All right. Thank you. So I'll take this question. Would you use FLOT, EOX, or chemo RT for my patients? So first of all, I never use EOX. I think that was not pertinent to necessarily this presentation, but I think we have proved that epirubicin, it really doesn't add much to these patients other than toxicity and making them sick. So I really don't use epirubicin. And then I was, before this data come out, I was really many times will favor the perioperative approach for the G-junction tumors. I think this trial was very encouraging to me in terms of using chemoradiation, particularly in patients that might have more lymph nodes that anyone will like, just because the degree of downstaging on the end, and we know that the end is very associated, post-op is very associated with recurrence. Plus now we have the data of the use of adjuvant nivolumab after someone gets chemoradiation, and you see that if someone just gets the chemoradiation, which is very similar, it was like 11 months, and then when we, in terms of progression for survival, and then when we add the nivolumab, it goes to 22 months, I believe. This is disease-free survival data, is not overall survival data. So I think in the bigger sense, the jury is still out there. But based on these presentations, I'm definitely thinking then, particularly for the G-junction ones or the upper, the esophageus, I am starting to favor more of the chemorad, just because I know that then I can still do the adjuvant nivolumab afterwards. We don't have data yet whether or not adding nivolumab or pembrolizumab to FLOT in this perioperative setting is going to have an impact. So I can't do that yet, but now I know with the chemorad. So I hope it answers to some extent the question.
So I've gotten a couple of questions on immunotherapy and autoimmune medical problems such as myasthenia gravis, or somebody mentioned multiple sclerosis. So in those patients, so obviously anything that I say is not an absolute. I'm not saying that anybody with an autoimmune disorder should be getting immunotherapy. I think it's a very personalized decision. This wasn't presented at ASCO this year, I don't believe, but there has been data that shows in patients who have uncontrolled autoimmune issues, and in certain patients who have, for example, myasthenia gravis, things like ipilimumab or pembrolizumab can indeed cause an exacerbation or can cause worsening myasthenia gravis. And in some people, it actually induces a new diagnosis of myasthenia gravis. So I think that it's a very personalized decision. I don't think it's an absolute contraindication, but I think it's something that really needs to be discussed extensively. And you have to talk about risks and benefits and talk about potential complications with the patient, and then it should be a shared decision. I think it's a conversation that needs to be very open, and you need to tell the patients this is a possibility. It's not as common, but it is a possibility, and then talk about what their particular risks are. Is there myasthenia in well controlled, or is it something where it's not very well controlled? So I think that, again, it's not an absolute. Everybody who has an autoimmune disorder is not going to have potential side effects, but it is an informed decision that needs to be made, having a very honest and open conversation with the patients.
Yeah, that's great. I couldn't agree more. Then another question that came, any difference between adenos and squamous carcinomas? And I take it as came from the HPV session, so we're probably talking about upper GI. Yes, so I think they are biologically different. As a matter of fact, if you look at the TMB rates, squamous is much higher than adenos, so I think they are biologically different. And I think I commend all the investigators that are actually breaking down the two, the studies in focusing only on squamous versus focusing only on adenocarcinoma. So yes, I do believe they are different, and we can see, especially when it comes to response to immunotherapy.
So another question I was asked was looking at patients who are with metastatic colon cancer who, instead of receiving active maintenance therapies, are going to be in the active monitoring group. And the question was, how often would I check CEAs and how often would I get imaging? So that's a great question. And I think it's really user dependent. I think different physicians, I've been on panels before where we've all kind of had a similar idea, but I think it really depends on who you talk to. So for me personally, if a patient has a CEA that I've been able to track in the past, where I've been able to see that their cancer is responding appropriately to a CEA, I typically will check CEAs initially every 4 to 6 weeks, because at least at the beginning of the active monitoring phase, I want to make sure that we're not missing out on a recurrence that happens more quickly. Once they've been stable for a few months, and then I usually space it out to 6 to 8 weeks. And then if they're stable for a significantly longer time, then you can sometimes even space it out to every 3 months. When it comes to imaging, I usually initially, again, I'm a little bit more aggressive. I usually get the first set of imaging about 8 to 10 weeks after I start the active monitoring process, unless I know their CEA is very sensitive. And in that case, I will usually space it out to every 3 months. And after that first scan, if I feel comfortable and I feel like they are stable and that their cancer seems to be well controlled still, then I would usually space it out to maybe 8 to 10 weeks and potentially even longer, the longer that they're stable on the active monitoring regimen. I'm curious, Dr. Soares, when you have patients who are on not receiving maintenance therapy, so metastatic colon cancer patients who are not getting maintenance systemic therapy, who you're just kind of monitoring them, how often do you check imaging and CEAs on them?
Probably in about every 3 months, and then I try to, when they are on treatment, monthly CAs, and then if they're taking a break, then I'll just do every 3 months as well.
Yeah, and that's
the metastatic setting if they're going to a break.
Yeah,
I usually
space people out to every 3 months after that first kind of 8-week period. And if they're stable at that time, then I move them out to every 3 months. I think it gives me peace of mind more than anything.
Yep.
But I like that first 8-week kind of test, and then I space them out to every 3 months, and it helps them with their mental status as well, because then they're not stuck seeing me every month as they were before. So,
yep.
Okay.
Oh, I have a question here. Based on the new data on chemo plus nivo or EP plus nivo, would you offer this first line even if the PD-L1 is less than 1% in the squamous cell? So let's start making a little bit less complicated. In the patients that had a score that was higher, and they don't have a lot of bulky disease, I think discussing chemo-free approach with just immunotherapy is very reasonable. I think if a patient has a lot of symptoms of bulky disease that you need response, then you have to start with chemo plus immunotherapy, but not just dual immunotherapy, because the responses with immunotherapy take longer. And then we know that is mainly in the patients that have a higher expression of PD-L1. The patients that have less than 1%, we saw that the responses are less impressive, and the duration of responses are not so different. So for these patients that I might be a little bit hesitant. I just want to point it out also that maybe this will change, because the authors, when they were presenting the keynote 648, they hinted that they're going to have a new presentation in one of the upcoming meetings, showing rather than PD-1 expression, actually a CPS score. And then the presenter actually even mentioned in the discussion that, if I'm recalling correctly, about 80% of these squamous carcinoma patients actually had a CPS score of more than 1. So I think when the next meeting comes, we'll be able to answer the question a little bit better, because there's also the difference between the PD-L1 expression versus the CPS score, and hopefully that will come.
Great. Another question I get asked when it comes to patients who are MSS, so who are not MMR deficient, those patients who are MSS status, would you give them immunotherapy? And my answer is, for now, no. We don't have any good data showing that those patients respond. So I still reserve immunotherapy for my colorectal cancer patients who have MSI high. I would not do it in somebody who is MSS, because we have all of the data and all of the studies have been negative in that particular patient population. So I would not give immunotherapy to those patients.
Agree with you. Then I have a question here asking, I'm quite happy Cross did well. It was easy to give weekly carbotaxol. Perhaps the radiation doses are a little bit different. Yeah, I think in the US we do a little bit higher, but My understanding is there hasn't been a lot of difference because of that. And I'm not a radiation oncologist, so I'll leave it like that for now. And apologize that I'm not diving on this question a little bit deeper.
The next question I have is, what about comparing pembrolizumab to nivolumab? So in the colorectal cancer setting, I don't think we have any head-to-head direct comparison trials that have looked at the two. I may be wrong, but off the top of my head, I'm not thinking of any direct comparison. So I don't think I could really give a great comparison as to the outcomes comparing the two. I will say that I do think they're both great drugs, and I think it really depends on, sometimes it's physician preference, sometimes it's scheduling. So, you know, nivolumab you can give every 2 weeks or every 4 weeks, and pembrolizumab you give every 3 weeks. So sometimes the scheduling, I think people choose based on that, but I don't think there's any studies looking at the two in direct comparison.
Great. There was another question about difference in treatment outcomes with gender, that women might be doing worse. I don't think we have a good biological explanation yet for that. This is also some of the subgroup analysis. I think now that the studies are starting to bring that, we'll start to see more biomarker driven in terms of things related to gender. I think nobody has a good explanation for why females will do differently at this point, unfortunately. And hopefully in the next few years we'll be able to answer that. I don't know, Dr. Jane, anything that you can think of in terms of the gender disparity, I mean?
No, I think, to be honest, I'm really hoping that with this data and with the knowledge that women do a little bit worse, that we might be able to actually do some subgroup analyses and potentially even set up some trials looking at that, because I do think it'd be interesting, and it's not something that we do a lot of research in. So I do think that that would actually be a really interesting trial, and potentially subgroup analysis to follow up and potentially see if there are other things that set the female participants in the trial apart. So I have a question about what percentage of MSI high patients do I find? So I guess the question, if I am interpreting correctly, is how many MSI high patients do I see in my clinic? I will say I don't have a lot of MSI high metastatic colorectal cancer patients. It's not the predominant type of colorectal cancer that I personally see in my population. I do have a few. So I've definitely tried immunotherapy in a few, and they've all had pretty good responses. So I utilize it every time I get that on my path report, but I do not have a very large population of those patients.
Okay, great. And then someone asked us before about was there any reasonable explanation from why in the adjuvant trial after chemoradiation, nivolumab was initially every 2 weeks before switching to monthly. And honestly, I don't think so. I think it's because just the trial started early on. There was, we start seeing the changes in the how long can we go with dosing. But other than that, I don't have a good explanation. From the patients that I have started for now, I'm following the trial religiously and doing every 2 weeks before I switch to longer.
Great. I'm going to see if I can answer one last question before we have to close this. Time really, really flew by. So I think one of the questions I have is, what do you do for neuropathy in patients who are on oxaliplatin specifically? And so I personally use this again. I don't think this was presented at ASCO this year, but I used to use a lot of gabapentin, and recently I've transitioned over to using a lot of duloxetine in my patients, and that they seem to do much better with duloxetine. That's something that actually I incorporated into my practice as soon as the data came out showing that it was well tolerated and that it did well. So duloxetine, I usually start at 30 and then I go up to 60, depending on how well patients tolerate it. So that's what I typically do. Well, Dr. Soares, this was like a rapid fire 20 minutes. So I want to thank all of the participants who joined us today and for your really insightful and excellent questions. Now there's going to be a quick break, so you can use this time to earn some points towards the Engage and Win giveaway. You can chat with the industry representatives in the exhibitor halls. Within their booths, they actually have some helpful resources and information. And there's also the ability to talk with available available booth representatives now. So you can use the break time effectively and enter into this giveaway. And Dr. Soares and I are both always happy to answer any questions. You can find us both on social media as well. So thank you so much for joining us on this lovely Saturday, and have a good rest of your weekend.
Thank you. Bye-bye.